Welcome back to the Therapeutics Chronicles. I'm your host, Momen Wali, and in part 2 of our corticosteroid masterclass, we are going skin deep, literally. Today, we are focusing on topical corticosteroids. If you are a pharmacy student preparing for board exams or a practicing pharmacist refining your dermatology game, this episode is designed to be your go-to reference. These are among the most frequently dispensed medications in community practice, yet somehow also some of the most frequently misused. Misuse is not just about over-treatment or under-treatment. It is also about wrong potencies, wrong sites, wrong vehicles, and yes, even the wrong patient expectations. We are going to break it all down, how these drugs work, when to use them, how to dose and counsel patients properly, what safety red flags you cannot afford to ignore, and what kinds of errors pharmacists catch in practice all the time. By the end of this episode, you will be confident about when to recommend hydrocortisone versus betamethasone, how to explain fingertip units without confusing the patient, and how to identify steroid misuse early. Before we dive in, if you have not already joined our pharmacy board preparation community on WhatsApp and Telegram, now is the time. Links are in the episode description. And if you are on LinkedIn, come connect with me. I would love to build a professional network with passionate pharmacy minds like you. Let's get started with what makes topical corticosteroids pharmacologically special. Topical corticosteroids work by activating glucocorticoid receptors in the skin, which then leads to the suppression of multiple inflammatory cytokines and immune pathways. They decrease capillary permeability, reduce leukocyte migration, and inhibit the release of inflammatory mediators. What this translates to clinically is a reduction in redness, swelling, itching, and discomfort. They come in a wide range of potencies from mild to super potent. In Canada, the classification generally follows a 7-class system, with class 1 being super potent and class 7 being the weakest. Betamethasone dipropionate 0.05% in optimized vehicle is an example of super potent steroid, while hydrocortisone 0.5% cream would be on the mild end. Topical steroids are indicated for a range of inflammatory skin conditions, including eczema or atopic dermatitis, contact dermatitis, psoriasis, seborrheic dermatitis, and insect bite reactions. They are also commonly used in hemorrhoid creams and for treating external genital inflammation. However, it is crucial to remember that not all inflammatory skin conditions are steroid responsive, and some, like rosacea and perioral dermatitis, can actually worsen with steroid use. Now, let's talk dosing, administration, and patient instruction, because this is where most of the confusion happens at the counter. Unlike oral medications, we do not talk in milligrams per kilogram per day. Instead, we use fingertip units or FTUs. One FTU is the amount of cream or ointment that is squeezed out of a standard tube nozzle along the length of an adult fingertip, and it covers approximately 2 adult handprints of skin. For example, to treat both arms, an adult might need around 3 FTUs per application. The frequency of application is typically once or twice daily, and duration should generally not exceed 2 to 4 weeks for higher potency products, unless explicitly directed. It is critical that we communicate this clearly to avoid prolonged use that can lead to local or systemic side effects. Let's consider the vehicle too. Ointments are occlusive and provide better penetration, making them ideal for dry, scaly lesions. Creams are better for moist or weeping lesions. Lotions and solutions are ideal for hairy areas like the scalp. Foams are especially useful for quick absorption and patient preference. A key part of our job is helping patients understand why their steroid comes in a certain form and how to apply it correctly. Always instruct patients to apply a thin layer, gently rub it in until it disappears, and wash hands afterward unless the hands themselves are being treated. Also, educate them on when to stop, either after symptom resolution or after the maximum duration advised by their provider. Patients must not use topical corticosteroids as long-term maintenance therapy unless under specialist supervision. Now, let's shift to what pharmacists must know to protect patients. The adverse effects of topical corticosteroids can be local or systemic. Local effects include skin thinning, atrophy, striae, telangiectasia, perioral dermatitis, and increased risk of skin infections like tinea or bacterial overgrowth. Systemic absorption is more likely with high-potency agents. Prolonged folds use, large surface area, or use under occlusion. This is especially critical in pediatric populations where the body surface area to weight ratio is higher. Another major concern is tachyphylaxis or loss of effectiveness over time with continuous use. That's why we sometimes recommend steroid holidays or intermittent therapy. Contraindications include untreated bacterial, viral, or fungal infections at the site of application. Precaution must be taken when applying near the eyes due to the risk of glaucoma and cataracts. Pharmacists should monitor for prolonged usage, refills without medical supervision, and signs of inappropriate use like perioral dermatitis. And remember, topical steroids can cause rebound flares if stopped abruptly after long-term use. So a tapering plan may be warranted in such cases. Alright, let's walk through some real-world pharmacy cases you might actually encounter on a busy shift. Case 1. A patient comes in asking for refills of betamethasone valeriate 0.1% for what she describes as a rash under the eye. Upon probing, you discover she's been using it twice daily on her face for over 3 months. Alarm bell. Facial skin is much thinner and more susceptible to steroid-induced atrophy. The pharmacist here appropriately intervenes, contacts the prescriber, and the therapy is changed to hydrocortisone 1% with strict time limitations and instructions for tapering. Case 2. A father brings in a prescription for clobetasol 0.05% ointment for his 3-year-old's eczema. While the drug is potent and effective, it is not first line for pediatric atopic dermatitis. The pharmacist, recognizing the high potency, confirms with the physician, and the prescription is changed to a medium potency steroid appropriate for a pediatric use like mometazone furoate 0.1%. Case 3. A patient applies topical steroid generously and wraps the area with cling film overnight, believing this will make it work faster. The self-initiated occlusion significantly increases absorption and systemic risk. The pharmacist catches this during counseling and provides education on the dangers of occlusive therapy without medical supervision. Case 4. A dermatology clinic calls to say they are out of betamethasone dipropionate in optimized vehicle and want to substitute it with betamethasone valeriate. The community pharmacist explains the difference in potency and the formulation, ensuring the clinic understands this is not a one-to-one substitution. Ultimately, the substitution is approved with dosage adjustments. Case 5. A woman with chronic psoriasis insists on long-term refills of a potent steroid for her elbows and knees. You notice it's been dispensed monthly for almost a year. As a pharmacist, you initiate a review with her provider, resulting in a switch to steroid-sparing agent for maintenance like calcipotriol, and reintroducing the topical steroid only for flare-ups. Each of these cases reinforces how pharmacist vigilance prevents harm and improves care. Before we move into our counseling simulation, a quick word about university. If you are studying for pharmacy board exams or want structured clinical content with real case integration, university courses are a game changer. Join our study groups on WhatsApp and Telegram using the links in the episode description. We dissect the cases like the ones we just discussed and help you prepare smarter. Alright, let's move into a 90-second dream counseling simulation. Just as a refresher, DREAM stands for D, direction for use, R, reason for use, E, expected onset, A, adverse effects, M, monitoring. Let's simulate a pharmacist counseling a patient picking up mometazone furoate 0.1% cream for eczema. Pharmacist: Hi Sarah, I see you are starting mometazone cream for your eczema. Let's go over how to use it properly. You are going to apply a thin layer to the affected areas once daily. Rub it in gently until it disappears. And make sure to wash your hands after, unless your hands are the area being treated. Now, this cream works by reducing the inflammation and itching in your skin. Most people start seeing improvement in just a few days. But it is important not to use it longer than 2 weeks unless your doctor says otherwise. Some people can experience side effects like mild burning or stinging, especially at first. If you notice skin thinning or worsening irritation, stop using it and give us a call. Also, keep an eye how your skin responds. If it gets better, great. If not, or if it comes back right after stopping, check back with your prescriber. And never apply this to your face unless you are told it's okay. Any questions? And now it's time for our rapid fire board style Q&A session. Let's reinforce those high yield pearls. Question 1. Which class of topical corticosteroid is the most potent in Canada? Answer: Class 1, such as betamethasone dipropionate in optimized vehicle or clobetasol propionate. Question 2. True or false? Ointments provide greater penetration than creams. Answer: True. Question 3. What is the risk of prolonged high potency steroid use on the face? Answer: skin atrophy, telangiectasia, and perioral dermatitis. Question 4. Can topical corticosteroids cause systemic side effects? Answer: yes, especially when used over large areas for prolonged durations, under occlusions, or in children. Question 5. What is the role of fingertip units in topical steroid use? Answer: FTUs help standardize dosing and prevent overuse by guiding patients on how much to apply per body area. And that brings us to the end of today's episode on topical corticosteroids. We covered mechanism, uses, dosing, safety, real pharmacy cases, and counseling essentials. If you found this helpful, do not keep it to yourself. Subscribe, share it with your colleagues, and join our Telegram and WhatsApp groups to keep the learning going. This is Momen Wali signing off from the Therapeutics Chronicles. Catch mistakes before they catch you. See you then.